Overall, just to make sure everyone's on the same page, PGTA, preimplantation genetic testing for aneuploidy, is a technique where once the embryos reach the blastocyst stage of development, days 5, 6, 7 after the retrieval, we do a biopsy and take some cells from the wall of each embryo, the trifecta DIRM, freeze the embryos, and send these cells for chromosomal analysis. So we find out which of the embryos are chromosomally normal, which are abnormal. It's a powerful tool. It's not 100% accurate, but it's very good. It's like 98% accurate. And it is particularly useful for those who are at higher risk of having embryos that are chromosomally abnormal. And that is largely predicted by the woman's age. So the woman's age predicts the chances that the embryos will be normal or chromosomally abnormal. So PGTA is particularly useful for those who are at higher risk of having embryos chromosomally abnormal. So generally that means women ages 36, 37, 38, and higher. Where we draw that line is not entirely clear. The women who are younger are more likely to have chromosomally normal embryos. Therefore, PGTA is not going to make a huge change in their chance of success. And that's pretty much what clinical studies have shown us, is when we did PGTA for younger women, it did not statistically improve their chances of success from an IVF cycle. And you can understand why that would be, because if we find a chromosomally abnormal embryo, we can't fix it. We simply know not to use that one. And so the cumulative chance of success will be the same from the cycle, regardless whether PGTA was used or not used. Either there will be a normal embryo that will eventually hit and succeed with if we didn't do the testing, or with PGTA, we go straight to the normal embryos to shorten the pathway and hopefully reduce the costs and the frustration of doing multiple transfers. So PGTA is a very valuable tool. For some people, it's extremely helpful. For others, it's not helpful much at all. And so that's a decision that's individually made with your doctor, and something that I always discuss with my patients prior to starting an IVF cycle to see if it makes sense for them to use PGTA for their journey in the given cycle. So PGTA requires that we delay the transfer of the embryo. In an IVF cycle that we're going straight through with a transfer of a fresh embryo that it's not being frozen, from the start of the stimulation medicine to doing the transfer is about 3 weeks. So we're going straight through. We stimulate the ovaries, takes about a week and a half for those eggs to grow. We do the retrieval, take the eggs from the ovaries, combine them with the sperm. They grow in the laboratory for 5 days, and we do a day 5 blastocyst transfer. That's about 3 weeks from start to finish. If we're doing PGTA, we're not doing the fresh transfer at the end of those 3 weeks. So we're taking any of the blastocysts that appear viable and doing a biopsy, freezing the embryos. We're sending these cells for chromosomal analysis. It takes 2 to 3 weeks to get the results. And then in a subsequent cycle, we prepare the uterus, thaw a good embryo, and put it in. If we go as quickly as possible, then the very next cycle after the IVF cycle is completed, we could be starting to prepare the uterus, thaw the embryo, put it in. So maybe a month, month and a half after the retrieval, a transfer could be done with after PGTA. Or if someone is not in a hurry or has other things that they need to be doing, if they need to address any health issues, do a hysteroscopy, do something that's required for work or travel, you can keep these embryos frozen as long as you wish and come back in 3 months or 6 months or a year, whatever the scenario is in any individual case. But clearly, doing the PGTA will delay the transfer because we need to wait to get the results. And then only if we have a normal embryo that's been frozen do we need to prepare the uterus, thaw the embryo for a transfer.